Hi guys, so I'm going to present a patient that I saw in my last rotation. She's a 20-year-old G2P1 black female who presented at 35 weeks and 5 days for a routine obstetrics exam of an uncomplicated pregnancy. And her complaint was that she was having clear, odorless vaginal discharge, which she noted at the beginning of her pregnancy, but it had been increasing in quantity over the last 3 days. And she denied any pelvic pain, pelvic pressure, vaginal bleeding, uterine contractions, or cramping, and she did have regular and active fetal movement. Past medical history significant for an uncomplicated vaginal delivery of a full-term infant. No surgical history. Family history of diabetes, hypertension, hypercholesterolemia, and heart disease. Social history, she did drink until her 12th week of pregnancy when she found out that she was pregnant, but she hasn't had anything to drink since. She denies tobacco use and drug use, and she's at high risk for getting an STD considering she's had multiple sexual partners over the last year, and she denies consistent condom use. She takes a prenatal vitamin daily, and Tylenol is needed, and she doesn't have any drug allergies. Her physical exam showed a blood pressure of 116/84, pulse of 69, respiratory rate of 20, temperature of 98.4, fetal heart rate of 138, and a fundal height of 36 inches. And speculum exam showed a closed, thick cervix without lesions. She did have some minimal, thin, clear, non-odorous vaginal discharge, and there was no pain with her speculum exam. Labs showed a low hemoglobin and hematocrit at 9.4 and 30.3, as well as a positive Group B strep culture. So the assessment and plan for this patient, she's pregnant at 35 weeks and 5 days, so she should be educated on the benefits of breastfeeding and then advised to follow up in 1 week for a reevaluation. And if she has any regular prolonged contractions, bleeding, broken water, or decreased fetal movement, she should be advised to go to the hospital. She should also be educated on the importance of STD protection, and she should be evaluated for premature rupture of membranes using an amnosure test. The Group B strep positive culture should just be addressed when she goes into labor or does have proven rupture of membranes, in which case she should just be given ampicillin 2 grams IV initial dose and then 1 gram IV every 4 hours until delivery. The anemia of pregnancy, she should be giving 65 milligrams over-the-counter iron daily. So my research addressed the premature rupture of membranes issue just because 10% of term labors and 60% of preterm labors have premature rupture of membranes, and there's not currently a gold standard that really addresses the issue. Historically, nitrazine and FERD tests were used, but they're not extremely accurate, so recently biological markers found in the amniotic fluid have been more popular. So the study that I looked at was a meta-analysis that compared the placenta alpha macroglobin 1, or PAMG1, to the insulin-like growth factor binding protein 1, both biological markers found in the amniotic fluid that can be used to diagnose premature rupture of membranes. So my clinical question was concerning pregnant reproductive age female patients with clear vaginal discharge suspicious for premature rupture of membranes. Does PAMG1 or IGFBP1 have better specificity, sensitivity, positive predictive value, and negative predictive value? So the conclusion of the meta-analysis was that the sensitivity and negative predictive value of the two tests were statistically equivalent. But the PAMG1 test showed higher specificity and positive predictive value, but only in the case of suspected rupture of membranes. In proven cases of premature rupture of membranes, the PAMG1 test and the IGFBP1 test were equivalent. And the study also noted that 90% of data on PAMG1 testing and 20% of data on IGFBP1 testing have been gathered from studies where there was an exclusion of bleeding present. And this is significant because the PAMG1 testing isn't accurate in cases where there's been vaginal bleeding. It messes up the accuracy of the test. So comparing the PAMG1 test to the IGFBP1 test, where there's been this exclusion, may mess up the comparison of these two tests to each other. So further research could be done that doesn't exclude vaginal bleeding from the criteria for patients, just to see if it is a significant factor in determining the accuracy of these two tests. And then also, research could be done why a positive predictive value and specificity of amniture is higher with suspected rupture of membranes versus proven rupture of membranes, just to see whether this is a testing error on the PAMG1 test, or whether perhaps it is picking up otherwise undetectable premature rupture of membranes.